Hello, hello.
Yep. I know.
It's important to.
I know.
Look at you guys. Bright and cheery.
We had to be. We didn't have much of a choice. Professor Carol.
Well.
Well, if you want to do good on farm, on
Do
NCLEX,
you have print up?
or on this test,
I do. PowerPoint kind of thing.
no, we're just talking. You can have your,
You have your
pu-
blueprint?
pull your blueprint up.
I posted the
Oh, like our.
pull up your every blueprint.
Yeah, free.
Yeah, farm time.
Oh, I did.
So I just get to. No, but you have, but they're back to back. There we go. Example is, logic application.
Oh, yeah, that's time. I don't.
Yeah. But once we get going, it's like boom, boom, boom. Yeah.
And that's why we're doing this today, because this is like your last class day, because then all the rest of the time you have exams.
Find it here. Real nice.
Well, except remember, I don't think you have class on the 29th, so you don't have anything that day. Because isn't that a Wednesday? Because she told me she was, yes, so you don't have anything that day for her.
Do you go where dynamic quiz is and then with all the extra tests and stuff?
Good morning.
That's right.
But it took me forever to find and then it was slap me in the face because I was like, I wasn't prepared to do this right now. And so that's the only thing I got out of all.
But that's good. I'm glad I'm glad we need some 151s. I thought those capstone.
We definitely need them. It was just like.
Yeah.
I wasn't ready for the you said
The learning system. It's physiologic adaptation and.
Wait, what did I say?
Exam 2.
Is physiologic adaptation. With 10 management care questions, and then exam 3 has a 9 management care question, and then farm has 21 farm questions, and then reduction of risk potential, which is very similar to safety and.
Yeah.
Has some similarities to it.
Well, if you think about it, when you're giving medications, what do you have to think about a lot of times?
Right.
Safety.
Yeah. So this is, you guys, yeah, we're doing the farm review, which is on again. It's our last class. I mean, like our last in person, like our last meeting. After this is just.
When is the last meeting again?
Well, I mean, I'm
Well,
just see if we're gonna be.
Testing, but last time to be in this room.
We have at least 400 questions, so we have to do. Oh, actually, I have.
That's good. It is good. I've been worried about you guys because the API stuff, I'm like, we're not doing enough questions like we were before.
No, we're doing plenty of questions. Yeah. I forgot what week it was. It was like earlier, like 3 weeks ago maybe. I forgot to do the capstone like exam.
You can still do the exam and you should still do the exam, but you're not gonna get the funds for it. But you should still do it. And I don't have any control over it.
It will be a
Because
most
I'm
points.
not they're just gonna give me a total. Like I can see what you guys have done and I can see the exam. And their recommendation is you go back and do it. If I'm 40, thinking NCLEX.
I did it.
So, what is the impact of losing the points?
Do you think this product will help you?
Well, there's 230 points total on capstone.
Mhm.
And do you guys remember how they're divided up?
Yes, it's 10, 10, 10, 10.
Yeah, so, right, so I don't think it'll be huge. And then that grade will go into your assignment grade,
Mhm.
which also includes the VATI stuff and it includes like the things that the other little assignments.
So it's part of
Will
the
do.
assignment.
So I don't think it'll be huge. But we've never done it before, so we'll see.
This poor group.
Post-
This poor group has been.
I know, post is 11, yeah, 10 points.
So you can get 30 points a week
Well,
total, and 10 comes from the pre-assessment, 10 comes from the content assessment. I don't know how they tell what they've done a content assessment.
Yeah, we do that too.
It's the biggest, isn't it?
It's the big one.
It's the big one. And then 10 points comes from the post-assessment.
So I was like, my question is like, after getting all the 230 questions or points, where are you going to apply them? In the
It's gonna
assessment,
go in the assignment.
in the assignment part of it?
Yeah, so it'll be 1 grade in the assignment. Yeah, which makes it, they're telling me.
Interesting.
The total weight of assignments.
Assignments is 15%. So it's gonna be 1 grade in there with all those other grades that are on. And then the VATI is the same thing. The VATI is 200
Yeah.
points total, but
That's-
it's 1 grade.
That's good information to know,
Virtual stuff.
because then we may need to let our people know.
Becca was saying there's a survey at the end, who's like, is this gonna help you with your clicks?
No.
Not really, cause it's not set up that well.
She said that like when she
She knows.
do it, okay, okay.
That's what we.
Well, you guys, I mean, you guys can set up your own quizzing.
We learned how to do
And
word
that-
vitals. We have word vitals. so
Okay,
we
well,
can-
good.
And so we're doing that now. That's the piece that I feel was missing.
Okay,
before.
because
That's kind of
we'd had board
equivalent.
vitals available, but then
My,
it,
my only thing on.
ATI
vitals
bought
that
it
we have
out.
to Figure out is, so in Pass Point, I didn't give you a number of questions. I just said you had to reach this mastery level. And that's not how Board Vitals is set up. And so we gave a number of questions in each client need, but I'm kind of thinking like they should keep going until they get like an 80 or an 85. And they have, and they have a combination of difficulty, like they can set. I don't know, how long, it doesn't take you guys that long to do 50 questions. Most of you are doing them in like 20 or 30 minutes.
I took my test. 16 minutes.
Yes. See?
Yeah, I think that is a.
See,
No,
as
that's
far as-
I
That's
do
just
not
so bad.
like to sit there and ponder a question for 5,000 years.
Okay.
well, and that's okay.
because
You really
it's
shouldn't.
Go like this, and I'm like, I'm not doing that.
At this point, that's
I
how
know.
it
But-
does.
I know
So,
it's
but
not
the-
enough.
The other thing I need to tell you guys too is what I tell farm students all the time is cover your answers while you're reading the question.
Yeah.
And think about what you know about what's the question's asking you, and then try to pull a question out of your head before you look at the answers.
I mean,
I tried
you're-
to do that with acute pancreatitis, and I expected NPO, and then there was no answer.
But is that the only thing that you would
Yes,
expect
but
with
we-
acute pancreatitis?
use
I
that-
picked a PO med, I was stupid.
Right. Expecting NPO that you could
With,
do.
it was a PO med with pills, and I was like, I am a fool. And it was valid. I did not pick the IV med, and I should. And
You're, yeah, the NPO should have taken.
Well, yeah, because that thought process of being NPO would say, okay, well, if my acute pancreatitis will most likely be NPO, then why am I going to give them something PO?
no,
But
exactly.
not only that, but think about this, too, they're also in a lot of pain
Yeah.
with acute pancreatitis, so,
Okay. No, I have.
well, but we're gonna probably giving something IV.
That patient takes or
Like, oh, this client.
It
is PO,
depends.
and the right answer was give them.
Usually
meds,
no.
Like PO.
The
meds.
answer would be.
Well,
Small.
But
sips
some
of water.
There are
But you
times,
can do without, it's the NPO with medication. So really, I
no,
don't know what you want from me. So you can't tell me, oh, they.
well, but look at the other answer choices, and if the other answer choices make absolutely no sense,
I'm just saying.
I know. I hear you.
Because they're making an exception, right? Because as soon as you take that pill with a small sip of water, you kind of stirred up the gastric juices. And the whole point of being an NPO is to.
But there will be times when you are told to give them a medication with a small, because that's the only way it's given. And they have to have it.
That's the answer is no. NPO.
Have you ever thought of something?
But she said, no, she said she got an answer
You got one of those?
that said, give the medication with small sips of,
It was give them meds that were PO.
with a small sip of water.
That is where I normally get confusion.
Yeah.
Have you ever thought of sublingual medications?
Well, but not everything comes sublingual. Not everything comes IV, not everything comes PO, so you have to also think about that. So it may not, yes, while sublingual would be a good choice, is that an option for that, whatever particular medication?
You guys are gonna be so happy when you've done your NCLEX.
Yes. Over there.
And then you're just working, and then you have other things to do.
And then you'll be on the floor and you'll have students come.
I need to be happy until I see it in class, but.
Yeah, well, because there's a lot of stuff you need to know about labor and delivery that you can't just get on the floor.
$75 for NCLEX.
Have you done your?
I paid $75 for NCLEX and I came to the other one.
You're paying for your portal to set up your account,
Oh,
and you're gonna have to pay $200 for the test.
No, I'm okay.
You found the jurisprudence exam?
Okay, wow. You see,
Yes
what
or
I
no?
just, they told me, no. You know, the problem is you don't want to understand my question.
Oh,
You're just jumping over with the links. Understand my question. Where will I get whatever? After I have registered, they told me to wait a week. So my problem is, how am I going to get it?
The jurisprudence exam?
Yes,
It
where
should show up on
exactly
your
within the everything, because I have the link, I can log in, but I cannot get it in between there, that is the question. The question is not the
It
link
should show up on your.
Yeah, it should just show.
in the portal. Yeah, probably.
And that's why.
And so
I can log in because I've set the portal, I can log in, you know, you understand?
you got plenty-
I'm sorry, I'm not hard on that, I'm sorry for that, but only I wanted to know whether it's.
My answer are behind it.
Okay.
All right, so,
Because Lauren is here.
oh,
I want to document it.
Thank you.
all right, so let's start. I'm good. I think, well,
I'm recording.
you're,
So we recorded all that.
yeah, we call that.
The conversation we recorded.
All right. It may not, my study guide may not be in exactly the same order that yours is, but it should be pretty close. So cardiac MI. What are the main MI meds that we give? Nitro is one. What's the mnemonic you need to remember? Mona, so what is it? Morphine?
That's all I got.
Well, she said one of them, nitro.
Not the
Mm.
A. The A. Oh.
Look at your blueprint. Yes, it is. Yes, it is. Well, not the oxygen. So I just gave it to you. So you may want to turn the lights on if you're writing up there on the board. Aspirin. So Mona, morphine, oxygen, nitro, and aspirin, not in that particular order. Because what can you give outside of the hospital before they get to there? Maybe, or the aspirin, right? So aspirin, why do we give them aspirin? What? Yeah, that's for MI. Why do we give aspirin?
To dissolve a clot.
Does it dissolve clots?
Yeah.
What does it do? It thins the blood. So what it does, it prevents platelets from clumping together or aggregating together. So it doesn't dissolve a clot. That would be
Prevents the clots from coming together.
alteplase or something that ends in ASE. All right. That's what we call those thrombolytics or the clot busters. Now, aspirin is preventing platelets from clumping together to prevent future clots from occurring. All right. So that's one of the reasons why we give the aspirin. Now, afterwards, they're usually on an aspirin a day to keep those platelets from clumping together. So you got to think about it. If they're on that aspirin a day, how many milligrams is it usually? You guys remember? Not quite. 81. It's 81 milligrams or 325 milligrams. It could be either one. So if you see 81 or 325 milligrams once a day, that's usually the baby aspirin.
This is the.
Well, yeah, but they could take either 81 or 325 milligrams. Now, the 325 milligrams can also be given for pain or inflammation or something like that, but they're usually taking 325 to 650 milligrams, and they're usually taking it more often or more times throughout the day versus for the MI, they're only taking it once a day.
Remember Mr.
I
Babowski?
was gonna say that.
He was taking mega,
His stomach.
yeah.
Well,
he was taking-
exactly, because that's the other thing. What do we have to be careful of with any NSAID?
Oh, GI.
GI bleeding, right? All right. So you have to be really careful. Any aspirin, now a lot of times the aspirin that we give, a lot of times will be enteric coated. So then it does not start breaking down in the stomach, it starts breaking down in the intestine.
We have the tonics with the aspirin.
They can. They can. Or something like that. They could do, well, okay. We'll talk about another one because we use it for something else as well. That originally was a GI med. Just that for given, we use it in OB.
Look at that. Oh, Cytotec?
Cytotec, absolutely. Originally, Cytotec was given for people that were on NSAIDs to prevent them from developing ulcers.
Yeah, because it relaxes the smooth muscles.
Right.
Yeah.
But what we found is it actually contracted the smooth muscle because it helped that uterus contract because we normally give it for postpartum hemorrhage or very low dose to induce them. All right, so nitro is the other one. Tell me about nitro. What do you remember about nitro? What?
Wait, it's sublingual.
So yes, it is sublingual, but can it be given any other way? It can be given, that's sublingual. Yes, it can be given as a patch. It can be given through the IV as a drip. It can also be given PO. There's some nitroglycerin. So when would we use the sublingual nitro? What kind of emergency? Heart attack, but why would they have nitro? What do they have before it could lead to a heart attack? Chest pain. What? Chest pain is, starts with an A, angina. All right. So they have angina. So they have chest pain. So what's the first thing we tell them to do if they start having chest pain? Before they take the nitro, we tell them to lay down, rest, because a lot of times the rest will take care of it. If not, then they take one sublingual dose. How many can they take? Up to 3. How far apart? 5 minutes. What do they do after they take the first one? They don't get any release. If they don't get any relief after that first dose, exactly, have them call 911, because most likely if that first dose doesn't help, something else is going on. But then you can give another dose in 5 minutes and then a third dose 5 minutes after that, but they better be on their way or close to the emergency room. What do we, what are some of the side effects from nitro? Common side effects.
Low blood pressure.
Yep, it can drop a blood pressure. What does nitro do to the blood vessels? Dilates them. So if they dilate, what might they have? A headache? So what happens when people have migraines? Their blood vessels in their brain are dilated, so when they dilate, they get the headache. With nitro, we're dilating blood vessels, so we're also dilating them in the brain, so they can have that, they can develop that headache. They may be flushed. They may have nausea and vomiting, dizziness. What medication is contraindicated with nitro? Y'all need to know it. If they're taking that medication, they cannot take nitro.
Interaction.
Yep. Anything for ED, erectile dysfunction, sildenafil, tadalafil, anything for erectile dysfunction. If they are on that medication, they cannot take a nitrate. Because what happens with the ED meds is it will drop a blood pressure. If we're giving nitro, it can drop a blood pressure. So giving them together can tank a blood pressure. Erectile dysfunction meds. Any erectile dysfunction meds, they should not take nitrates of any kind. So sildenafil, sildenafil.
You guys know.
Anything that ends in FIL is usually an ED med. What do we need to teach our patient about the sublingual nitro?
It needs to be in a dark.
Dark container, preferably the glass bottle with what kind of cap? Well, yeah, but is it a plastic cap or it's a metal cap and there's no cotton fillers in there? The other thing to tell them is when they use that sublingual nitro, they may feel a slight burning sensation. That's normal and that's a good thing because it lets us know that it's still maintaining its potency. Usually once they open that bottle, it usually lasts for about 3 months. And then it will start losing its potency. Now, could they put it in one of those, there's like those other like little metal pill containers in that are like airtight. If they have something like that, that may work as well, because sometimes it has a key ring on it. They can keep it on their keys. But it has to be in a dark bottle or away from the light and away from the heat. All right. Oh, what do we tell them about if they're using nitro patches or any kind of patch? Take off the old one before they put the new one on, right? Why? That patch still has some medicine in it, right? So we could be overdosing our patient if we're not careful. And what do we do to that site? Do we just leave it? Do we just kind of wipe it off? Do we put the patch back on that same site? No, we're going to put it on a different site, right? And what about the sites that we're using? Make sure that they're clean and dry and hairless, right? Because we don't want, because hair doesn't allow it to stick very well. All right. All right. And of course, we talked a little bit about oxygen, morphine. What do we have to worry about with morphine? Blood pressures. What is the other big thing we worry about with opioids? Yeah, absolutely. Sorry. Respiratory rate. Yes. So if their respiratory rate's really low, sorry, I didn't hear what you'd said. I apologize. Oh, well, that's true. Very much so. That's a side effect. That's a common side effect. Yes, you have to worry about that. What do we give them if they overdose on opioids? Narcan. Narcan is now also in a spray. All right. Did y'all know there's another one out there that's in a spray that I just found out not too long ago?
Do we need to know it?
You may. We'll talk about it. We'll talk about it. Okay, heart failure. What kind of meds do we use for heart failure? Oh, wait a minute. Sorry. There's one other thing to think about with acute MIs. What after they have the acute MI, are they put on any other kind of potential medication? I didn't have this one on my notes, but I was thinking about this on my way in this morning. Is there something else that after they have an MI that we can put them on to help either prevent further MIs or sudden death? Well, the class starts with a B. No, not benzos. Beta blockers. Because beta blockers decrease circulating catecholamines, and those catecholamines is what irritates the heart. So a lot of times we put them on beta blockers to decrease that and hopefully prevent them from having another heart attack or sudden death. And we'll talk about beta blockers here in a little bit. Heart failure. What are the main classes of drugs we use? You talked about it. Diuretics. Furosemide. I'm so glad I have help. I never even thought about writing on the board.
I don't know if it helps.
It's great, because I'm gonna take a picture.
Yeah, it just helps.
You can't see it in the recording. Should I shift the camera?
Well, no, you can actually see it. You can see it.
They should be.
You can see it. I mean, I don't know how well you can see it, but it's on there. So what is usually besides diuretic, when would we give a diuretic? I mean, what diuretic do we use? Furosemide. Why do we give furosemide? It's a loop diuretic, yes.
To get rid of excess water.
Yes. Why? Why do-
Potassium sparing.
It's not potassium sparing, so you need to know that, so we need to keep an eye on their electrolytes. But why do we give furosemide and not something like hydrochlorothiazide or spironolactone? It it is easier on the kidneys, but it works really quickly. If we give them IV Lasix or furosemide, it's going to work. They're going to start diuresing in a matter of minutes. Even if like 5 minutes.
It's crazy.
It is crazy how
doctor,
fast.
like, they have her for open heart, and I would give it right before we got in the car to go to school, and we barely made it
Mhm.
without
I have
having
to
an
do
accident.
like 4 urinals at a time.
Yeah, well, and my mom had congestive heart failure, and every time she knew that she had to go into the hospital and get furosemide, she's like, put a catheter in me. I'm like, you would rather have a catheter? And she's like, yes.
Yeah.
Well, they didn't have PureWix 10 years ago.
Oh.
So, or 11 years ago or whatever. Yeah. So, all right. So, the other thing about it is the trade name is Lasix. And do you know why it's called Lasix? Because it lasts 6 hours.
What did you say?
It lasts 6 hours. Lasix. LASIX. Lasts 6 hours.
The body moving, like. is that-
Not that surgery.
How timeline, the timeline is 6 hours?
Well, it just, in the body, the duration of action is about 6 hours.
Nice.
All right.
Yeah.
So we have them on, if they have heart failure, what are we having them do daily? Weigh themselves, right? Because that's going to let them know whether or not they're retaining fluid. Usually 3 pounds in a day, 5 pounds in a week. If they're, that's letting them know. So what would we assess on our patients that are coming, if they're coming into the hospital to see if we need to give them Lasix? Why would we be giving them Lasix? Not just, fluid overload, but where? Lungs, yes, absolutely. They're filling up with lungs. So they may have a cough, they may have diminished breath sounds, they may have crackles, that kind of stuff. What is our first line treatment for patients that have congestive heart failure?
The med.
Mhm.
I'm in service, so yeah, I think.
There's 2 classes that we use primarily now as first line treatment for congestive heart failure. We were talking about one of them earlier. ACEs and ARBs. Your ACE inhibitors, your angiotensin receptor blockers, right? What is the other medication you may see a patient on for congestive heart failure? It's not first line treatment anymore. It used to be first line treatment. That's what we put everybody on that had congestive heart failure. But we don't tend to put them on it as much anymore, but you may still see patients on it. The cardiac glycoside. She knows. Starts with a D. Digoxin. God, I'm having to give you guys too many hints. No, I'm just kidding. So digoxin. What do we have to be careful with digoxin? Heart rate. So we have to monitor their heart rate, right? How do we apical pulse, right? When do we hold it?
6.
Below 60,
Yeah.
right? Do we have to worry about any other labs with that, with Dig?
I forgot what it is.
So I know what you're trying to say. It has a narrow therapeutic index. So between the effective dose and the lethal dose, very close together. So we do periodic blood tests. Do you guys know what the therapeutic level is for Dig?
I think I only have to do my head right now.
No,
Yeah.
that's too high. 0.8 to 2 nanograms per milliliter.
I only have 0.6 to 1 million.
Uh-huh.
0.8 to 2.
0.8 to 2. 0.2 to 8. No, wait, no. 0.8 to 2.
2.
Yes, sorry.
It's important I write it down right.
Yes,
We don't have
0.2, no, 0.8 to 2.
To 2 now.
Yes. Yeah, very good. That's good. That's it. There's something else really important that we have to worry about when they're taking Dig. They could kick them into Dig toxicity. So it's an electrolyte. Potassium.
Always potassium. Always potassium.
Well, why? Why is it always potassium?
That's what the heart rate.
Exactly. Sodium is going to affect the brain. Potassium is going to affect the heart. Conduction. Calcium affects muscle, also affects bones, but it affects muscle, which can also affect the heart because the heart is a muscle. But potassium is going to affect, so sodium, when we see abnormalities in sodium, we're always going to see some kind of neurological issue. Confusion, lethargy, that kind of stuff. Potassium can affect the heart conduction. So if we're not careful, if the potassium gets too high, what can happen to that heart? It can stop. That's what we give people on death row
Oh, yeah.
to kill them, basically. We're giving them
That's
potassium chloride. And we open it's in an IV bag and they don't know which one it's in and they open all of them. Because remember, if we are giving potassium to a patient through the IV, what do we have to be careful of? It has to be diluted, and we usually have to have them on telemetry because we need to monitor that conduction. Even if it's too low, it's still going to affect the conduction pattern. So what are some, hypo or hyperkalemia? Oh, sorry, hyper or hypokalemia going to cause them to be in Dig toxicity? Hypo. So what are signs of Dig toxicity?
The halo.
Yes. If you walk into their room and they say, oh, you have this wonderful yellow glow about you, and they're on Dig, the hair on the back of your neck better stand up because they're probably becoming Dig toxic if they're not already. What happens to what about their heart rate? Why do we give Dig? To slow down the heart, right? So if it's really bradycardic, they may have nausea, vomiting, dysrhythmias. What is the antidote? Digibind. Or digoxin, you may see it digoxin immune fab. Same thing. So digoxin has 3 different tropic properties. It's an inotropic, dromotropic, chromotropic. It's a positive inotropic drug because it's going to do what to, inotropes do what to the heart? It increases the contraction. So it helps the heart contract better. It has a negative dromotropic effect, which will decrease the heart rate. And then a negative chronotropic. Sorry,
That's what I'm thinking out loud.
decreases
Chrono.
negative chronotropic. It's going to decrease the conduction. So basically kind of helps slowing it down.
Are those the motor or?
Sort of, yeah, it's kind of like how it works. It's going to increase contractility, decrease the heart rate, and decrease the conduction. The main reason why we give it though is to slow the heart rate. So what do we teach our patients? What do they have to do before they take it? Monitor their heart rate. If it's below 60, hold it and
Oh, yeah.
call their doctor or call their provider. Absolutely. All right, so we already talked about your,
That I think. I told you guys about my med error.
Oh.
We gave Jidge and enalapril twice a day, liquid form. And so at some point, for years, and at some point, my daughter would just come up and I'd open the refrigerator and stand there and draw it up and shoot it in her mouth, and draw it up and shoot it in her mouth. And one day, my little 18-month-old son came up and stood next to her, and I just shot it at him.
Hey, grow up, grow up, grow up, grow up.
yeah.
Oh my gosh.
I mean, it can happen. So we talked a little bit about furosemide already, so we have to worry about potassium and them wasting potassium, right? What can we have them do if they're taking it to help with their potassium levels? Yeah. Is there any food we can tell them to eat?
Bananas,
Bananas.
avocados.
I think, yeah, anything high in potassium. We may also have to give them potassium through the IV, which we already talked about. If they take, have you ever seen potassium supplements, the oral potassium supplemental pills?
They're ginormous.
They are huge. I mean, I don't even know how people swallow them. They're like, yeah, they're like, I call them horse pills because they're so big. It's like something you would put in a horse. All right. So that's pretty, I think that's it about furosemide. So of course we're monitoring, what else would we monitor on our patients if they're taking a diuretic? Besides their weight? What would we monitor on our patient? Urine output. Not only output, but also what they are taking in. So the INO. Pretty strict INO too, right? And then daily weights. How do we tell them to weigh themselves?
Same scale, same time of the day.
Same clothes. Yep. Yep. Best time to do it is when, you know, I do mine. I usually weigh myself about the same time every day and I'm on the same scale and same clothes. And I won't tell you what those clothes are. Not quite, but close. All right, so we talked about aspirin and what aspirin does. What are some of the other anticoagulants that you may run into? Lovenox or enoxaparin,
Heparin.
anticoagulants. Heparin, enoxaparin. What's the other big one?
I've never seen them taking warfarin.
Yes. And there are certain people that can only take warfarin. There are other oral anticoagulants out there, but there's one type of person that can only take warfarin. And they can't take any of the other types of oral anticoagulants.
But
If they have a mechanical heart valve. If they have a mechanical heart valve, they can only take warfarin. If they do not have the mechanical heart valve, there are several others, clopidogrel, like Plavix, Eliquis, Xarelto. So there's several others that they can take. But we're mainly going to talk about kind of heparin, enoxaparin, and warfarin. Because those are the three main ones that you, a lot of times when you see these, there are certain things you gotta remember. So, yes.
Good question.
It has something, yeah, it's the way, something with the way the blood flows and why warfarin is the best option for them. Yeah, well, we actually have, and she's been really cool about letting people listen, like when we've done interprofessional sims with them. Dr. Jackie Hamilton is one of our professors, and she has a mechanical heart valve. And you can hear it. So if you ever get a chance to, and somebody has one, listen to it. But she is on. And she would probably, I mean, she would probably even come to your class, come to the class one day and I mean, yeah, I know you're not having any more classes after this, but. Yeah. So heparin. How do we dose heparin? Or how can it be given?
In an IV and 200.
IV,
It's a little,
it's usually a little bag. It can be given any other way?
the only way I've seen it. And I
Okay,
just
well,
know-
heparin can also be given sub-Q. It can be given like enoxaparin. But, so let's say we're going to give it IV, how is it dosed?
That depends on your level. You have to get APT?
PTT, not INR. We'll talk about INR in a minute. INR, we do test for one of them,
Warfarin.
warfarin,
INR.
PT and INR for warfarin. So, but let's kind of go back to heparin. Whenever we are going to initiate heparin therapy on a patient, what do we have to have an accurate account of?
I mean, their weight.
Their weight, because we dose them based on that weight. Right?
And this information about the PT. I normally see PT and PTT.
Right.
What's the difference there?
It's one is prothrombin time and the other is a partial thromboplastin time. So they're looking at two different types of coagulation factors in the blood and how fast they clot. So heparin is the PTT,
Difference.
right? And then the dose will change based on the PTT because we're having to maintain them within a certain range. What is the complication we have to worry about? Bleeding. That's, any kind of bleeding when they're on any kind of anticoagulant, right? We don't tend to see it as much with the Eliquis or the Xarelto or that. And because we don't have to do routine labs for them. And even enoxaparin, we're not necessarily doing routine labs on them, but heparin and warfarin, yes.
Let me tell you, they kill your period. Like gushing.
Yeah.
Gushing period.
Yeah. It is. I mean, because they're thinning everything, right? So
Correct.
one of the things that can happen when we have somebody on heparin is called HIT. Heparin induced thrombocytopenia. And basically what's happening, it's very rare, but it's the body's immune system kind of develops antibodies against the heparin and it causes platelets to clump together and then they're destroyed. And when they're destroyed, then it leads to a low platelet count. And their platelet count can drop in half if they have HIT. So they can't clot, right? And
Is that
So-
a complication?
it is a complication, and if they do develop HIT or HIT, what do you think we do? We're gonna stop the heparin, probably have them on something else. What is the antidote for heparin? Nope,
Proton.
yep, protamine sulfate. Now, vitamin K is for warfarin. Good guess, you were close,
But know them.
but you gotta know them. All right, enoxaparin, how do we give enoxaparin? It's sub-Q. It's usually in a pre-filled syringe, and what does it have in there that we don't get rid of?
Air bubble.
The air bubble, because the air bubble acts like as a seal, so that none of the medication comes out. Where do we give them? Where do we give enoxaparin? In the love handles, right? After I had my gastric sleeve, I got enoxaparin a couple of times, and I went home, and then I was looking in the mirror one day, and I was like, why do I have these bruises on my belly? And I'm like, oh, duh, Amy, they gave you enoxaparin, and that's where they gave it. So we really, so we don't necessarily have to worry about if they do overdose or they start bleeding on enoxaparin, we can usually give them protamine sulfate, but we don't tend to see it as much with enoxaparin. That's why we tend to use it. It's usually a very low dose, and we can give enoxaparin to pregnant women. We will not give them warfarin or anything else. We will always give them heparin or enoxaparin. All right, so let's talk about warfarin. How's it given? Oral. Heparin is IV, all right, or sub-Q. And we use the PT for that, or the PT and the INR, sorry, PT and INR. And I always love when you guys would come to do OB Sims and we would talk about the clotting factor or clotting studies, and everybody always say INR, and I'm like, no, that's just for warfarin. It's the only time we really use the INR. What do we want the INR to be for them to be therapeutic?
Don't remember.
2 to 3. 2 to 3 times. When do we start them on warfarin? All right, so think about this. How long does it take warfarin to become effective? That's very important to remember. It usually takes 3 to 5 days to reach therapeutic effect with warfarin. So are we going to have them on just warfarin? Waiting for it to become therapeutic? What else would we have them on? Probably heparin. So they come in with some kind of clot. We start them on heparin, and then we initiate warfarin therapy. So they're on them at the same time. We get the warfarin to therapeutic level, then we take away the heparin. What do we tell them? What do we teach them about how to take care of themselves at home? Fall precautions, absolutely. What about shaving? Electric razors. What about brushing their teeth? Soft toothbrush, right? So anything to try to prevent bleeding. What else would we tell them to do if they're going to be on any of those medications for a long period of time? What if they are in an emergent situation? What should they have? Yes, a medical alert, some kind of medical alert system so that people know that they're on that medication. In case of surgery, or if they're injured and they're unconscious, we need to be able to know. And because we need to, if they are bleeding somewhere, we need to know how for them to take care of themselves. And then of course the antidote, vitamin K. Now, where do they get vitamin K? Do we get vitamin K on a regular basis? We only give it, Can we get vitamin K any other way?
Food.
Exactly.
Oh.
Exactly. So what would we tell them to do? Like spinach, any green leafy vegetables, something like that. So what do we tell our patients that are on warfarin? Well, do they have to avoid them altogether? In moderation, and they need to be consistent in their diet. We don't want them to eat a whole big spinach salad one day. And then because what are they doing to the effect of the warfarin? They're messing with it. So they need to, and they will go in and have periodic blood tests done as well. All right. So I think that's pretty much it for heart stuff.
Even me, concern, even that you talked about the anticoagulants. Maybe, do you consider to talk about the thrombolytics? Maybe.
Okay, well, I can talk about them because when everybody okay with her erasing that? You wanna take a picture? Anybody want? Okay, okay.
Maybe.
All right, so while we're doing that, because that's not really one of the medications that you have to be worried about for this test, but it is important to know, and it could show up on any other test. We give a when would we give a thrombolytic? There's, why would we give a thrombolytic, or when? If they have a clot
Yeah.
somewhere, and it could be in the heart, or it could be in the brain. So if it's a stroke, one of the things that we have to do when they come in with stroke symptoms is we have to figure out what kind of stroke it is. Is it an ischemic stroke, or is it a hemorrhagic stroke? Because if it's a hemorrhagic stroke, we're not going to give the thrombolytic because they're already bleeding. And one of the side effects or adverse effects of a thrombolytic is bleeding. So they have to be aware of that situation. So we always send them to CT or MRI to determine if it's a stroke, if they're having a stroke symptoms, what kind of stroke it is before we can give them any kind of medication. Hemorrhagic. Is it a thrombotic stroke or is it a hemorrhagic stroke? Because we need to know if we can give the clot buster or not. And then they need to know that one of the potential adverse effects is bleeding. But most of them will go ahead and take it. And we can give it to them if they're having a clot in one of the coronary vessels, because anything past that coronary vessel is going to start dying if we don't get an oxygen supply established. But they can also send them to the cardiac cath lab to hopefully get that clot out or put a stent in so that it opens up the blood flow. Does that help?
We have the, maybe give us the examples of.
Anything that ends in ASE, alteplase, streptokinase. I think alteplase is like the most common one now. Anything that ends in ASE. Do you have the family names in Canvas?
I don't think I have.
Okay, if you don't have them, let me know and I'll make sure you get them again. The family names is always a good thing to download and look at, because a lot of medications, the classes they have certain things that we talk about. All right, asthmatics. What kind of medications do they usually take? Corticosteroids and bronchodilators, right? If they are on both the corticosteroid and the bronchodilator, which one do they take first? The dilator, because we want the airways to open up so that more of the corticosteroid can get deeper into the lungs to decrease that inflammation, right? So when we're talking about bronchodilators, there's two different types. There's the short acting and the long acting. What do we use for acute attacks?
Sure.
The short acting, right? The long acting is what we're usually going to give along with a lot of times that corticosteroid. And now a lot of them are combined. It used to be that we would tell them to take the bronchodilator, and then how long do they have to wait in between medications? 5 minutes. If it's the same medication and they're doing like 2 puffs, then they wait 2 minutes. But if it's 2 different medications and 2 different inhalers, then they wait 5 minutes in between. What do we have to be careful with corticosteroids? What do we tell them to do after they take it? Rinse their mouth and even rinse the plastic the spacer or the canister part, not the metal canister, but the plastic thing that you put the canister in, rinse that out because of why? The rush. Because it is a steroid. And when we give a steroid, what are we doing to the immune system? We lower their immune system, and that's why they can develop thrush, which is oral candidiasis. But yeah, like I said, nowadays, a lot of them are combinations, so they'll have the bronchodilator and the corticosteroid in one. I would probably still have them, because they do have the corticosteroid in it, I would still have them rinse their mouth. Now, we have to be careful because we have two different types of inhalers. We have the MDIs and we have the DPIs. MDI is metered dose inhaler, so that's where it's the canister. But then we have the DPI, which is the dry powder inhaler. And it's usually, yeah, it's like in the circle, Advair is the one I can think of the most. And it's a dry powder, so we don't want them to get that wet. The meter dose inhaler part, they can get wet, but not the dry powder because it's a powder. We don't want them to get it wet. I think that's pretty much, and there is Montelukast, which is the oral medication that they can take for asthma. But I think mostly it's kind of like the big ones are the bronchodilators and the corticosteroids. All right, OB meds, preeclampsia and PIH. What medication do we use for PIH or even preterm labor? I'm sorry? Okay. Well, pregnancy-induced hypertension or preeclampsia. Oh, PIH is pregnancy-induced hypertension.
No, I was like getting confused with PPH, you know?
Oh, postpartum hemorrhage.
Yeah.
Yeah. So betamethasone we can give to them if they're in preterm labor. Yes, because what is betamethasone going to do? Helps the baby's lungs. But what do we want? What if we're trying to stop their labor? Or they're preeclamptic. What is the medication that we give them? Yep, mag sulfate, magnesium sulfate. All right, so but there's some things we have to be really careful with magnesium sulfate. One of the things is, and we used to fight the labs all the time, is we would want them to be in a range of somewhere between like what, 6 and 8. And for anybody else, that is like extremely high. Okay. So we had to fight our lab because they would always call us for a critical lab value when they were like 6. And it's like, no, that's what we want them to be. So we finally got that changed. But there are certain things that we have to be really careful of when we're giving mag sulfate. What are we doing when they're on mag sulfate? Say it again. Maybe. Neurocheck. So we're doing the DTRs. We're doing their vitals. How often are we doing all this? Every hour. So we're looking at DTRs. We're looking at their vitals. What else there's a couple other things we have to pay really close attention to. Some of it, a little bit of it goes along with their vitals. Respiratory rate, but we listen to their lungs because we want to make sure that they're not filling up with fluid. One other really important thing that we have to worry about when they're on that, urine output, right? And how much should a normal person put out every hour? Yeah, usually about 30 is your average. So am I getting this person up to the bathroom? Probably not. They probably have a catheter in. So we can, and they have the urometer. So we can accurately measure how much they're putting out every hour. We're in there every hour checking them, their vitals, their DTRs, their urine output, their lung sounds. Right? Usually we're giving it through the IV. And why are we checking all of that? For toxicity, because even though we would like them to be in a range of 6 to 8, we're not doing routine mag levels anymore. Because we usually will see them becoming toxic quicker with their changes in the DTRs and vitals and all that. All right, postpartum hemorrhage, what are the 4 main meds that we usually use? Cytotex 1. Methyl ergotamine, Hemabate or carboprost. Yep, Hemabate. There's one other one. Oh my God, the one that we give all the time. Oxytocin. So oxytocin is usually your primary one, right? Because that's usually what we use to induce to, but we can also use the misoprostol or Cytotec to induce labor, but a very small amount. Let's see. So if we're giving Methergin, what do we have to be careful of? Methyl ergotamine. 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 No, that's carboprost. We just talked about
A
it.
very strong vasoconstrictor.
We just talked about it. Hypertension. If they are hypertensive. Now, if you have somebody though that is hemorrhaging, their blood pressure may be 80/40 at that particular time, but what do I have to be careful of? What her trends were before she started tanking because of the postpartum hemorrhage. Her blood pressure is low because of the hemorrhage. When we fix the hemorrhage, what are we doing to her blood pressure? We're putting it back where it was. And if she was already hypertensive and I'm giving her Methergin, what am I going to do to her blood pressure? Not tank it. I'm going to make it go skyrocket.
Yeah.
And what could we do? If we shoot a blood pressure up too high, what can happen? Stroke. So while they may be hypotensive at that particular moment, I'm going to go back and look at the trends before she started hemorrhaging because I want to know what her baseline blood pressure was.
We have all these other options too.
And we do have so many other options. All right, so Hemabate, why do we have to avoid in asthma patients? Okay, so what?
It's a constrictor.
Yes, it's a bronchoconstrictor. So asthmatics already have issues with their airways, right? Do we want to constrict their bronchi anymore?
Which one's the generic name?
Carboprost.
Carboprost and
Mm-hmm. And oxytocin.
How do you know either one of these is? Whichever drug you're giving for postpartum, how do you know it's working?
They're bleeding.
When the bleeding.
They're bleeding less, the blood is coming from where?
The gene.
What are you doing all the time? What's your first action?
That's why I did that 5 months.
Great, so if your fundus is firm,
And the bleeding has slowed down, then you know it's working. All right. Okay, so now let's talk about Cytotec or misoprostol. This is the one that originally, when it first came out, was designed to prevent NSAID-induced ulcers. But in the process of us giving it, we found that it made the uterus contract. And if somebody got pregnant and they were on that medication, what happened?
what happens if you're early pregnant?
Miscarriage. It's basically a medication induced
This-
abortion.
Yeah, this is part of it. It's mifepristone and then misoprostol.
So we have to be very careful.
This is what progesterone levels, the other makes uterus contract.
Yeah. So we have to be very careful when we're giving that to not give it, but I mean, yes, it is contraindicated in pregnancy, but we use it towards the end to induce labor, but a very small amount.
On a standardized exam, you don't even think about pregnancy, right? You're, it's like, what do you want to What questions do you want to ask, or what do you want to ensure when you're giving Cytotec for GIF set? And the answer would be, check her pregnancy level, make sure she's not pregnant.
Yeah.
Because if she's pregnant, you want to do something else.
Yeah.
But when it's mixed in with all those other questions, you're not even thinking about questions, pregnancy.
Right. Because we normally see it in OB. So remember when you did your OB Sims and you came and sat at the table with me, and what did I say about hemorrhaging? A hemorrhage is a hemorrhage is a hemorrhage.
Oh, I do remember.
You're gonna see the same signs and symptoms for anybody that's hemorrhaging. We just treat it different depending upon where it's coming from. They're all gonna have changes in their vitals. What happens to their vital signs? Heart rate goes up, blood pressure goes down. Couple more. Respiratory rate increases, what else goes down? Exactly, they're O2 sat. When if they're hemorrhaging, I'm not worried about a temperature. Because the temperature really, it's a good thought, but it's not gonna tell me anything about the hemorrhage. But pulse rate and respiratory rate, blood pressure and O2 sat, that tells me a lot about their hemorrhaging. Right?
Noel, we massaged her fundus and went that way with Mr. Grabowski. What was the site of his? Remember? And the same thing happened to him, right? Where was he bleeding?
Where was he bleeding from?
Yeah,
GI.
right, so we did the endoscopy. MRIs.
But he had the same symptoms
Yeah.
as Noel did in OB. Because a hemorrhage is a hemorrhage is a hemorrhage. So if you think about it, they're gonna be dizzy, lightheaded, the room's spinning, they may pass out. They may be lethargic, cool and clammy. Anybody that's hemorrhaging is gonna be that way, no matter where it is coming from. We just treat it differently depending upon where the bleeding is coming from. So in postpartum, this is what we do when they're bleeding.
Do other ones to avoid
Not really.
anything?
Pitocin and oxytocin and Cytotec, we really don't, there's really no contraindications for either one of those that I can remember.
With heart rate, since on the very increased heart rate in hemorrhages, it's most of the early sign due to compensatory.
Right, they're trying to compensate, so they're increasing their heart rate.
Yes, then later on, it will be dramatic.
Yes, later on, the farther they get in, then it's gonna start going down. Right? Because after a while, it's gonna tire out. It's not gonna be able to do the work it needs to do. It speeds up to start with because yes, it's trying to compensate for that blood loss, trying to get more blood to the body, right? All right. Oh, lithium. Why do we use lithium?
Antipsychotic.
It is an antipsychotic, so it can be used for a multitude of different things like bipolar disease. It's a mood stabilizer, right? What do we have to be careful of with lithium? There you go. So what would we see if they were becoming toxic with lithium?
Your heart, or rhythm go crazy.
Yeah, they may.
Arrhythmias or
They have a certain.
or rapid heart rate?
Yeah, go back and look. So a lot of times toxicity, diarrhea, vomiting, drowsiness, muscle weakness, lack of coordination. It is. But if it's, and that's at a lower level, but if their level becomes too high, then it's gonna kind of go opposite. They may be giddy, they may have ataxia, blurred vision, tinnitus. They may also have a very large amount of dilute urine. Is there any specific treatment for lithium toxicity?
Get them off.
We treat them symptomatically and supportively. There's not always going to be an antidote for everything. If there is, you should know it. Usually when they become toxic, they're greater than 1.5 milliequivalents per liter. Is what I have on my notes.
Yes.
Yeah, 1.5 milliequivalents per liter,
Per liter of what?
or however they, milliequivalents, however they measure it. Yeah. All right, diabetes. What are the different types of diabetes that are out there? One and two, well, is that all? Gestational.
Sorry.
Oh.
Sorry. Need more room.
Oh.
Do diabetes. Okay.
Yeah,
You've done already, you've done already. So,
Okay, do I need to put it back?
No, you're okay.
Who's Mag?
No, that's fine.
That's all it said.
We'll be fine.
All right,
You're
it's on the, it's on the.
good.
All right, so type 1, type 2, gestational, right? Those are the big ones that we see. What are the medications that we use to treat diabetes?
Insulin, metformin, Ozempic.
Okay. All right, so think about, so what do we use for type 1?
Insulin.
Only insulin.
Yes.
Right? Now, I will tell you that years ago when we had our ABSN students, there was one that got diagnosed with type 1 and she was on insulin, but her doctor also had her on an oral hypoglycemic. And it was interesting, and I couldn't figure out exactly why, because normally they're just on insulin, right? They're not producing any, because their beta cells in their pancreas have been destroyed. Right. They produce insulin, but it is either not effective enough or not enough. I mean, it's not, it doesn't work like it's supposed to.
So if you're into the.
Right.
I was. Maybe because of your cotton candy thing. It just replays my head.
So what I did is I had 3 things of cotton candy, and you can do this at home, if you want. In one, what I said is whenever we take in sugar and we do not have diabetes, our body produces insulin. So you dump water in there, cotton candy goes away. For type 2 diabetes, we produce some insulin, so you pour just enough in there to start letting it melt, but it doesn't completely go away. And then type 1 diabetes, there's no insulin, so we have to give them an outside source of insulin in order for them to take care of the sugar or the glucose that they take in.
And type 1 is usually because they're born with it, right?
No, they're not necessarily born with it. They usually develop it in young age. It used to be called juvenile onset because that's when we tended to see it. Usually they were in their middle school age
Yeah. Like
to teenage.
Right, like maybe we.
Yeah, somewhere around there. Sometimes it can happen sooner than that, like 10 or 11 or something like that. What are the 3 P's that we look at for diabetes? Polyuria, polydipsia. Yep, exactly. So polyphagia. Increased urination, increased thirst, increased hunger. What else are we seeing if they're type 1? Even though they had this increased hunger, they're eating ravenously, they're drinking all this fluid. What are they doing? They're losing weight. Right? That's for your type 1. But type 2 will still have a lot of these, but the type 2 we used to call adult onset because most of the time we saw it occur in adulthood. But unfortunately, we are now seeing a lot more younger people with type 2 diabetes because of that insulin resistance. Their body's producing insulin, but their body's not utilizing it effectively. And they're overweight. Yep. Sedentary lifestyle, diet, not the best, right?
That's high sugar.
High fat, high sugar, high carb, yeah. A lot of, kind of the thing about the diet. So for type 2 diabetics, what can we use to treat it? So we can use the oral hypoglycemics, we can use the Mounjaro and Ozempic and all that, the weekly shots. We can also use insulin. Sometimes they will be on insulin as well. So let's talk about the insulins. What are the different types of insulins? Okay,
Cloudy, clear.
right? Okay, let's talk about that in just a
So
second.
they are cloudy.
Yes.
Except for this
So what is cloudy? Which one is cloudy?
short.
The intermediate acting. All right, so we have short or rapid acting. When you have the rapid acting, how fast does it work? 15 to 30 minutes, sometimes even less. Your short acting will usually take about 30 minutes or so. If I'm giving them a rapid acting or short acting, what do I want to have in front of them?
Sugar.
Food. I want them to have food, because if I'm giving them insulin, I could bottom out their sugar quickly if I'm not careful, right? NPH is the intermediate, and that is the one that's cloudy. All right. And then we have the long acting, which is clear. What do we have to remember about the long acting?
Usually given them.
It's given in the morning and it usually lasts about 24 hours. They say that it doesn't necessarily have a peak, but it's like that maintenance. It's like you have a little bit of a onset peak and then it lasts for a long period of time.
Say 15 to 30 minutes.
Rapid,
Short.
15 to 30, short is 30.
What is rapid?
Like regular.
So
Intermediate is the NPH
no,
and the intermediate is cloudy.
got that.
So how do we
I
mix
wonder
them?
about the numbers.
The intermediate
It's a 3 to 5
on
hours.
says like 6 to 12 hours. It's 3 to 4 hours. It lasts for 6 to 12 hours. So that's why a lot of times the regular or short acting are given together, the rapid or short acting. What do we draw up first?
Clear before cloud.
Clear before cloudy.
I have, I'll post an insulin
Short acting is 15.
sheet too.
It goes with rapid and short.
Are those interchangeable?
Short acting is 15.
Are those interchangeable?
Well, you can use a rapid or a short acting. It just depends upon what brand it is. Because you'll have the logs or the lins. Humulin, Humalog. Pretty much, they just work, one of them works a little bit faster than the other. Now, if it's a regular insulin, can that be given any other way?
Yeah.
Yeah, it can. And when would we use regular insulin the other way? And how would it be given?
Short.
Look it up. Tell me.
These are the questions.
I'm
Okay.
confused because we're going in between like the short and the rapid and then the regular and then.
Okay, so-
Long acting.
Short.
Regular is a short.
Regular short. Rapid and short are very similar. Rapid just works
Rapid.
15.
Completely different.
Yeah,
It works a little faster.
it just works a little faster, but they're still gonna work within 30 minutes.
So you want to feed somebody.
Yes.
So either one, no matter what, rapid or short acting, you want to feed them. If it is a regular insulin, we usually give that IV. And we're usually giving it to somebody who comes in what? Type 1, they're type 1 diabetic and they usually come in DKA, diabetic ketoacidosis. What else are we going to give them if we give them insulin? What? No, no. Good guess. We have to give them potassium. Because when they come in DKA, what is their potassium level like? No, it's high. Acidosis, pH or potassium is going to be high. But when we start giving them insulin, what are we going to do to that potassium level? We're going to drop it. So much so that we may have to give them potassium to level it back out again. So if they come in DKA, we're giving them regular insulin through the IV, and we're probably gonna end up having to give them potassium as well.
Need to figure it out, how does this make progression go down? Going to enter into the cells.
Yes,
But,
what?
In some cases, they also give them a little bit of the glucose to make sure that they don't take it too fast. so
They
it's a
may.
mix of the-
They could. Yeah. I just know that a lot of times when we give the regular insulin, then I haven't seen the ATI, so I honestly, and that could be very true, because if we don't drop, we don't want to drop it too fast, right? What are the signs of, low blood sugar? Yep, cool and clammy. All right, so hot and dry, sugar high, cool and clammy needs some candy. Although we don't really want to give them candy, we want to give them, what do we want to give them if their blood sugar is low and they're awake? Okay, is that the best option? We may, but really and truly, what we would like to do is we want to do a 15-gram carb load and then recheck their blood sugar in 15 minutes. But we want to do a complex carb, not necessarily orange juice or something, more like something like peanut butter or something that's going to last a little bit longer versus the orange juice, which is going to spike their blood sugar and then drop it again, right? Now, if we only have orange juice, then of course, that's what we're going to do. But we'd like to do, if they have a low blood sugar and they're symptomatic and they're awake, we'd like to do the 15-gram carb, complex carb, and recheck their blood sugar in 15 minutes. What else do we have to remember about the long acting? Something really important. Long acting insulin. It has to be given by itself. It cannot be mixed with anything else.
It'd be in the same.
Cannot be in the same syringe. It has to be drawn up by itself. So if you have somebody, and why are we, so we're giving, it's kind of like what we call, when they're in the hospital and we're doing the long acting and we're doing the rapid and intermediate, or the short, rapid or short and intermediate insulin, we're doing what we call a basal bolus. We're giving them, the long acting is like a maintenance, and then we're giving them that bolus dose, because when we give that bolus dose, what are we dosing them for? That blood sugar right then. We're not, so whatever their blood sugar was right then, that is what we're dosing. Yes, the short, the combination,
Like your daily.
daily maintenance dose, kind of like
Detamir is
Detamir, Glargine and Detamir are the two. Glargine. Glargine. Yeah,
I'm thinking this is, smooth strength insulin.
mm-hmm. Because and the reason why we do that is because we want that good long-term effect, but we also have to treat those periodic blood sugars. Because what their blood sugars do what to wound healing?
Oh, it's slow down.
Slows it down. So when we're doing in the hospital, we're doing their blood sugars, finger sticks, usually AC and HS before meals and at bedtime. What is the test that we do outside the hospital that lets us know that they've been under good control? The A1C, because that lets us know how they've been over how long? 3 months. The finger stick or the bedside glucoses is only telling us what their blood sugar is right then and there. It doesn't tell us how well controlled they've been. So we want to go with that hemoglobin A1C to see how well controlled they are. Right? Yeah, oh, that's the other thing. So if we're giving somebody steroids, what do we have to be careful of? Well, what does it do to their glucose levels? Their glucose levels will go up. We'll even see it in our moms that we could betamethasone to. If they're not diabetic, their blood sugar will go up. We just automatically know that when we are giving corticosteroids, blood glucoses are going to go up. So if they're diabetic, then we may have to adjust their insulin if they're on a corticosteroid. So what's the other big corticosteroid that we use, that we give people? Prednisone, right? What do we have to be concerned about with prednisone, since we're kind of talking about it? How do we take them off of prednisone? Do we just stop it?
No, you don't stop.
No, because it can cause adrenal insufficiency, right? So we have to taper them off. Always has to be tapered off.
Those are our packs.
Yeah, the,
Seven.
yeah, it's like a Medrol dose pack is one, it's like 5 pills, 4 pills, 3 pills, 2 pills, 1. All right, antihypertensives. What are the main classes of antihypertensives that we usually give? Antihypertensives. We kind of talked to them a little bit about when we talked about congestive heart failure and MI, ACE inhibitors, ARBs, and beta blockers. Those are, now they can also use like calcium channel blockers, but those are, calcium channel blockers tend to be used more for dysrhythmias. But for when we're talking about antihypertensives, ACE inhibitors, what do they end in? No. Prill. Prill.
You know what? They should end the names, right? Like-
Well, but think about it. So I think about it this way. ACE inhibitors. So think about like ACE, a pilot who's an ACE, you know, he pilots a plane really well, and he's out there for the thrill. Prill. I don't know. However you can think about, remember it. I had this cartoon where Snoopy was sitting on top of his doghouse, and he was the Red Baron. And that's how I always kind of think about it. What do we have to be careful of with ACE inhibitors? Or what is one of the common side effects that can happen? Right. It's not something that we necessarily need to stop the medication for, but it can be very irritating. It's what we call the ACE cough. And we may have to switch them. And if we switch them, we usually switch them to the ARBs because they don't tend to cause the cough and they work very similarly. ACE inhibitors are angiotensin converting enzyme inhibitors. ARBs are angiotensin receptor blockers. What do what? They work very similar, but the thing with this ARBs is they don't end up with that cough.
What do they end in?
ARBs? Ah, what do they end in? I always think of a sultan. A sultan with the, you know, like sartan. SARTAN. They all end in sartan.
I need to research
Saga?
more.
I know.
Well, you're retaking it right now.
Yeah, go to your lecture.
Like, please.
Yeah, I mean, that is part of why we're
Oh,
gonna do
yeah,
that.
losartan.
Losartan, yes, yep. So one other big thing we have to be concerned about that's an adverse effect of ACE inhibitors. Not the cough.
No.
It can cause something with an electrolyte.
Oh my god. The electrolytes, okay. I'm assuming potassium.
Yep. You will assume right, but which way?
I'm gonna go with,
Hyperkalemia. So that is one we have to be very careful of if we're giving spironolactone with, because spironolactone is a potassium sparing diuretic. So if we're giving a potassium sparing and ACE inhibitor at the same time, then we can really bump up their potassium levels if we're not careful. A lot of times now you'll see, like I take losartan, but I take losartan along with HCTZ to look for, they work together, because hydrochlorothiazide is a thiazide diuretic, and thiazide diuretics a lot of times were first line treatment for high blood pressure, like HCTZ, because it worked to lower blood pressure that way. So like I take losartan and HCTZ together. My husband, on the other hand, takes lisinopril and HCTZ together. So he takes an ACE inhibitor with HCTC and I take an ARB. But it's just doctor preference. Yeah, let's talk about beta blockers.
So
I know what
we haven't talked about
Did you
thiazides.
talk to your class?
Like, do they are in these classes?
Thiazides they are a diuretic.
Dr. Eaton's lecture.
Yeah,
Oh.
so, yeah, so I can, yeah, so, yeah. No. No, we already had a plan. She's finishing up the cardiac with them. And, so we gotta hurry up. Got a couple more things. So beta blockers, what do beta blockers end in? Lol. Laugh out loud. LOL. Laugh out loud. What do we have to, or why do we give beta blockers? There's several different reasons. Now, there can be. Now, there's like metoprolol, propranolol, atenolol. So, metoprolol a lot of times we'll give as an antihypertensive. We can also give propranolol as an antihypertensive, but propranolol is kind of a unique beta blocker because it can be used for a couple other things. We can give it for those that have migraine headaches. We can also give it to people for stage fright. So a lot of times nurses that if they have to go give the deposition, will take a low dose propranolol before they go give the deposition because it relaxes them.
I remember seeing different people who were like taking tests and like.
Test anxiety.
Like that, but, like, beta blocker does the job.
Because stage fright is, you get very anxious if you have to go and talk, like if you're going on stage for a big production, or think about this, if you're a nurse and you get called to give a deposition, meaning you're getting called into court, how anxiety provoking would that be? Okay, so that can help kind of relax people. But what do we? Decrease anxiety, that would probably work. And it also works for angina and essential tremors. So what do when we give beta blockers, who do we have to be careful of? And it's probably not a good thing to give a beta blocker to these people. We were just talking about it over here. Diabetics. Why? So what do beta blockers do?
Lower the blood pressure.
Lower the blood pressure and they lower the heart rate. So what is a diabetic's number one sign to themselves that they are becoming hypoglycemic?
Low heart rate. Low blood pressure.
Tachycardic. They become tachycardic. So if they become tachycardic, if we're giving them a beta blocker to slow their heart rate down, are they going to have that tachycardic sign? It's going to mask the signs.
Where are we going?
There.
Where are we going?
Well, I'm trying to get it out of you guys. Right. So it masks the signs of hypoglycemia. So we have to be very careful if we're going to give it to diabetics. We really don't want to give it to diabetics if we can avoid it. Of course, we talked about asthmatics because it can cause, what can beta blockers cause in asthmatics as well? Bronchoconstriction. So beta blockers can also cause bronchospasm or bronchoconstriction. What about in men? What can it cause in men?
Erectile dysfunction.
ED or impotence. Yep, they will have erectile dysfunction. What do we have to be careful of when we give, or what are the parameters to not give beta blockers? What does their heart rate have to be below?
60.
If it's below 60, we don't want to give it because
But they're
it's
saying like it has to be greater than
yes.
60.
In order to give it, it has to be greater than 60. What about their systolic blood pressure?
One greater than 90. Wait, systolic.
Greater than 100. Systolic. We want their systolic above 100. So if it's below 100 systolic or below 60 heart rate, we do not want to give it. We want to hold it and notify the provider. Because beta blockers, So remember, we have two different types of betas, beta 1 and beta 2. Beta 1s affect the heart, beta 2s affect the lungs because we have one heart and two lungs. Easiest way to remember.
Okay,
So you know what is one heart, two is two lungs.
Right. Beta 1, heart, beta 2, lungs. We have one heart and two lungs.
Makes sense.
Fantastic.
And you know what? That really fit together, girl.
It should be done.
It's okay. So we know what that's, yeah, we know what it is.
Just the heart, the lungs kind of like.
It's
Yep.
fine.
And
Oh.
Yeah, draw the trick the answer.
Yeah.
There you go.
Oh,
Yeah. Okay.
All right, levothyroxine. Why are we giving it?
Okay.
We're giving it to people with hypothyroidism. So it replaces the thyroid hormone. Which one? T4. How long is therapy? Forever, right? So we have to be really careful with our patients that are in the hospital if they've been on thyroid medication and they've been NPO for, let's say they're having surgery. We want to get them started back on that as quickly as possible, right? What do we teach them, the patient, there are clients about taking levothyroxine on an empty stomach. Same time, preferably early in the morning, right? And usually with a full glass of water. We want them to take it as just because it can, they need to take it really quickly because it can dissolve pretty fast. So, and will they have to have periodic labs? Yeah, because then we want to make sure that they stay within that therapeutic range, right? mm,
Why do you think it's prepared?
early in the morning.
Empty stomach.
On an,
You got
because
nothing in there.
if we have to have it on an empty stomach, because food can interfere and other medications can interfere with the absorption. But we have them take it on early in the morning because if they take it too late in the day, it can cause insomnia. It causes them to not be able to sleep if they take it too late. That's why we usually try to have them take it at like 6 o'clock in the morning is the ideal time, before at least 30 minutes before they eat. Preferably a little bit, like an hour before, or at least 2 hours after any other medication because of the way it's absorbed. We want it to be absorbed correctly. And if it's taken with something else, it may not be absorbed the way it's supposed to be. So remember your pharmacokinetics: absorption, distribution, metabolism, and excretion, right? All right, what do we have to worry about with opioids? CNS depression, mainly respiratory depression. What do we give?
Gotta find it.
Oh, come on, you need
You gotta write it down.
Narcan, right? And Narcan is now available in a nasal spray, and a lot of first responders carry it. And I think it's even being sold in stores now.
I've been thinking vending machines.
Vending machines.
Really angry about it because we're making it to where you're more likely to have.
Well, but we are also seeing such a bigger increase in fentanyl overdoses too. And we need, right, yeah. All right, pseudoephedrine, what do we use it for?
Girl, I don't know what that is. So.
Yes, you do.
Yeah, you do.
So they.
Pseudoephedrine. Sudafed.
Mucinex.
Well, Mucinex is guaifenesin.
Guaifenesin, yeah, what else?
Works different.
Susan.
Afrin nasal spray. So okay, so basically we're giving it for allergies.
Okay.
When we give pseudoephedrine, what do we have to be very careful with, or who do we have to be very careful with?
Isn't there a specific medication that you're not supposed to give over the counter?
This is it.
Oh, sure. Alcohol.
No,
Wait. There's an over-the-counter med, like.
pseudoephedrine, well, Sudafed, if you buy the pills, oral pseudoephedrine, you have to go to the counter. Because what can it be used to make?
Me.
Methamphetamine. Yes, they can be used to make meth. So you have to be very careful. Now, it's also sort of, it's a nasal decongestant. What?
I thought, isn't Sudafed cough syrup? No, it's cough syrup.
But cough syrup
What's
makes.
the-
Dextromethorphan, like Robitussin.
Robitussin makes the lean.
Yeah. So, but pseudoephedrine, we have to be very careful with people with high blood pressure. Because if we're giving them something that speeds things up, like if it can be used to make meth, what can it do to blood pressure and heart rate and all that? So we have to be very careful. Now you'll see a lot of cold and cough and allergy products that are specifically made for those of us that have high blood pressure. It'll say HBP on it or for high blood pressure because it doesn't have some of the ingredients that can jack up a blood pressure. But if we're giving it as the nasal spray, that's a nasal decongestant spray, we have to be very careful because they can only take it for a max of 3 to 5 days. They take it longer than that, they're going to have rebound congestion. 3 to 5 days. Congestion. All right, antilipemics.
An Afrin or example.
Yes, Afrin is the nasal spray.
Oh, right.
Pseudoephedrine. Oh, that's sorry. Statins. What do we use statins for? Yeah, it is. I think it's under there. Simvastatin.
Oh,
What do we use statins for?
it's spelled wrong.
Oh, yeah, it was spelled wrong.
It's a steroid. Search and everything.
Right, lower lipids, right? It's an antilipemic. What do we have to be careful with? So it's going to lower the LDL levels, low density lipoprotein. What?
The bad.
Lower the cholesterol levels.
It lowers the LDL, which is the bad cholesterol, right? We have to be careful when we give statins to certain people because they have to get routine labs done to check liver enzymes because it can affect the liver. What are the side effects of people with liver disease? Any kind of hepatic disorder, because statins can increase liver enzymes. All right, so if they have liver disease, we have to be careful. What are some of the side effects that we could see with, or adverse effects we can see with statins?
I do.
Oh, you guys are gonna like flip your lid when you hear this. Nausea, diarrhea, dyspepsia. It can increase glucose levels. Muscle weakness.
You say about.
It can increase blood glucose levels. Muscle weakness. Muscle weakness can develop into something more severe. Rhabdomyolysis. And when they have rhabdo, what's happening is their skeletal muscles damaged and it's breaking down rapidly. It causes muscle pain and weakness. And that muscle breakdown is harmful to the kidneys because it can cause kidney failure. And a lot of times that if they're in rhabdo, they will have tea-colored urine or very dark urine. And, or an irregular heartbeat as well. So muscle weakness, and if it gets too bad, can lead to rhabdo. What are the different types of allergic reactions? Yes, it's spelled wrong, sorry.
No, I spelled it
Oh. What are the different types of allergic reactions that somebody can have?
wrong.
Anything. Mild
Anaphylaxis.
to anaphylactic, right? So anything from a rash to airways closing up. What do we use if they're in an anaphylactic reaction? What do we use? Epinephrine. That is the new one out now that comes in a nasal spray. It's called Neffy.
Wow.
Yeah. One of my students from issues over the summer
Does it
has
last
one.
longer?
I'm sorry.
Is it like room temperature?
Yeah, I think it does. Yeah, because and it's a nasal spray now.
The EpiPens you give like through their clothes.
You can get through the clothes. Yeah, I mean, it works. I guess it works just as well. Oh, yeah, right. Epinephrine, Neffy. All right, blood transfusions. How do we give it? Or how is it administered? Or when you administer it, what do you need to go through? Think about. Right, who has 2 nurses, right? Right, you have to go through that whole big checklist. What type of IV fluids do we hang with blood? NS, normal saline.
Yes, you'll get to it.
Dextrose will break it down. Normal saline. When we initiate, how often do we do vitals initially?
15 minutes, isn't it every 5 minutes?
Everybody.
Every 5 minutes for the first 15, because if we're going to see a reaction, that's probably when we're going to see it. Right? And then after that, we can go to like every 30 minutes or so, but we're going to keep an eye on them.
How long do you have to hang?
4 hours, you have 4 hours.
It has to be infused within 4 hours.
What about how long you have once you get it from?
30 minutes, 15 to 30 minutes.
Go back and know compatibilities, like who can get what blood. What are the different types of reactions that can happen if we give blood? Febrile. Okay, so they can have there's 2 different main ones, hemolytic or anaphylactic. The hemolytic, a lot of times we'll see the fever, chills, nausea, vomiting, back pain, dark urine. And that's usually from an incompatible blood type. Anaphylactic, hives, swelling, difficulty breathing, low blood pressure is more of an allergic reaction. What do we do if they're having any kind of reaction? Stop it. And then what do we do with everything after we stop it?
You take it apart, you take it back, take it off.
Yes, we have to take it back to the blood bank. So we take everything. We'll put a new normal saline IV up and everything like that because we have to make sure that. Yeah. Yep. All right.
Very good.
I thought I saw Professor Hernandez out there, but oh, I saw her though.
She said she's close.
She's there.
Yeah, she's here. So
Yeah,
let's
we
take
need
a quick break.
Yeah. I know we've been going for
We've been
2
going
hours
for 2
straight.
hours. You guys have done great.
Thank you.
But you guys did awesome.
You did great.
I hope it helps.
Okay, slow it down.
I hope it helps. I know it's a lot of information.
I set it to record automatically, which I think makes it hard to pause.
Sorry, I went a little over.
There are slides, they're under Bible 8, and they're also under study resources.
Which one is it? The
The renal review.
Is it showing up there?
Oh, I gotta turn on this. Thank you.
See, I know.
This might be enough. You said 3?
Okay.
Module 3?
Module 8.
Oh, hello.
Module 3.
Sorry.
We're on week 8.
Not here, girl.
We're almost done.
Renal.
All right. Okay, we're good. Ready? Okay, so when I developed this PowerPoint, I actually made the slides mostly all to where you could download them, print them off, and it's a note sheet. Okay, so a lot of different key points at the bottom for you guys, things that definitely you'll need to remember for your NCLEX when it comes to the to renal disorders. Okay, so with the renal system, pretty much, of course, it has everything to do with the kidneys, right? And how the kidney functions. Something that I've been noticing is that a lot of the nursing students, specifically in med-surg too, I'm looking at when they're doing data collection, we're looking at the BUN, we're looking at the creatinine, but we're not looking at the EGFR, okay? EGFR tells us how much function we have left of the kidneys. Some patients can be a little bit over 100%. I think the highest I've ever seen is 123%. But then again, that was like a 14-year-old, okay? But once that number starts to come down, which normally after the age of 55, they start losing 1% of kidney function every year. Add comorbidities on there as far as diabetes, high blood pressure, and then them taking lots of medications, it's going to be a lot lower, a lot faster. Okay, so these are a couple of the functions that have to do with what your kidneys are responsible for. Your glomerular filtration, right? How much toxins we can get out of the blood. Regulation of fluid balance, right? So if I take in a bunch of fluid, can I also excrete the same amount of fluid, right? There comes in the intake and output, your eyes and nose. Electrolyte balance, definitely sodium, potassium are your main ones. We also look at your chloride level and then of course your calcium levels, okay? So if we can't filter out the calcium as well, what is probably one thing we might be at risk for when it comes to the kidneys? Kidney stones. Yeah.
That's what you meant.
I knew what you meant. Yeah. So kidney stones, right? Another factor that we also look at is the uric acid level, right? So your uric acid is not only in the joints when it comes to gout, it's also circulating in the circulatory system to where it'll affect the brain, it'll affect the valves of the heart, and then also the kidneys. Okay. So that is the second most common type of kidney stone. It's made up of uric acid. Okay. All right, acid-base balance. Hormone production, like erythropoietin. Have you guys ever seen where in dialysis patients, we have to give them erythropoietin because their kidneys don't function enough anymore. They don't make it. So we have to give them a synthetic type. And then of course, your waste removal, okay? So if we start seeing that your creatinine level is high, it's because we're building up that toxin. We need to try to excrete it out, okay? So you'll see that when your BUN and creatinine are high, your GFR is low. There's always an inverse relationship to those. All right, so again, you'll start seeing that they have decreased GFRs by probably age 70. My 70-year-old's always asking in clinic, what is my kidney function supposed to be at? Well, for your age at 70, about 70%, right? Because again, every year after the age of 55, you're losing something. The decrease in kidney size. So just as when we get older, we get smaller, so do the kidneys, okay? They start shrinking in size, all right? And then of course, aging structures. That just means like when you're with your males, prostate issues, okay? So meaning that they're withholding urine because their prostate gets enlarged. And then with females, it's mostly because of the pelvic floor, right? They have incontinence problems, more than likely too whenever they have a hysterectomy, their bladder falls because the uterus is usually what's keeping up the bladder as well, okay? So gravity's not necessarily, ladies, when we get older, it's not our friend, okay? All right. Okay. So big thing with the assessment part of your renal system is mostly just asking them a bunch of questions. It's all about your health history, right? If you think about the actual assessment of the kidneys, what is it that we do in order to do what is part of your assessment, your physical assessment when it comes to the kidney system, your renal system? CVA tenderness, right? What else?
Facial puffiness.
So edema, okay, what else? It's the shortest system to assess, right? We're assessing more like the urine production, intake and output, right? What the urine looks like, color, consistency, smell, don't taste it, okay? All right. Okay, so a lot of your assessment when it comes to the renal section is that you're asking them questions. How often do you urinate, right? Are you swollen that way all the time and it just never goes away after you wake up in the morning? Like from day to day, does it just stay the same over and over again? Okay. You're asking them about their history. Do you have high blood pressure? Why am I worried about your blood pressure being uncontrolled and then it's causing kidney problems? Why do we think? Kind of a double-edged sword, right? Because your kidneys are also partially responsible for your blood pressure, right? So if your kidneys are sick, your blood pressure is going to probably be all over the place. I have patients that have low blood pressure versus the high blood pressure. But if we have already a pre-existing condition of high blood pressure and it's not controlled, that's what's going to cause your kidney disease. Okay, so usually the golden rule is if your SBP, your systolic blood pressure, is higher than 135, always, it's stealing circulation and good oxygen and oxygen intake from the kidneys, right? So have you ever seen like in a septic patient, we want at least a MAP of 60 to know for sure that we're circulating enough pressure, enough oxygen circulation so that the kidneys stay alive? You remember that? Okay. So here we don't also want to steal from them by having too much pressure. So the golden number is 135. Your systolic blood pressure in a kidney patient needs to be less than 135 in order for us to make sure that we're getting enough oxygen to the kidneys. So that way they stay functioning correctly. Okay. Diabetes. Why do we want to make sure that your diabetes is controlled when it comes to kidney disease? What does diabetes cause? Starts with an A, ends in sclerosis. Atherosclerosis, okay? All right, which means hardening, right? Hardening of vessels, hardening of organs. So when we have uncontrolled diabetes, right, all that extra sugar is going to make the kidneys start to fail because the kidneys start becoming shrunken and small and hard. They're not able to be flexible enough to function, okay? So the golden number there is your A1C needs to be less than 7. That just means that your diabetes is controlled as best as possible. Your fasting blood glucose, if your A1C is less than 7, is less than 120. Okay, so if we're already diabetic, we want your fasting glucose to be less than 120. If we are not diabetic, your fasting glucose should be less than 100, right? Okay, so remember those parameters there. And then of course, whenever we have autoimmune disorders like lupus, scleroderma, ANCA, and then which turns into vasculitis, right? Okay, so autoimmune disorders, definitely the first organ they want to attack is the kidneys. Okay, the kidneys are responsible for so much. They literally operate different parts of the factory, right? They have lots of different responsibilities, but they are also like a teenager that the moment that you ask them to work a little bit harder, they throw a temper tantrum. They're the most fragile, finicky organ in your body, okay? Other than the brain, right? All right. So the more medications also that we take, especially the ones that are nephrotoxic, those are the ones that we need to really, really look out for. We have a problem in America, polypharmacy, right? Everyone likes to take meds for this, meds for that. You have a headache, I'm going to take Tylenol. Oh, that's not working, I'm going to take ibuprofen. Oh, that's not working, I'm going to take Excedrin. And they could take all of that in one day, right? And then add on that they have high blood pressure. Oh, I have a headache because my blood pressure is high. How about we take our blood pressure medicine instead of taking a Tylenol with your blood pressure medicine because you have a headache, right? So polypharmacy, we have an issue with that. What are some nephrotoxic medications that definitely, as soon as that patient is started on this one specific one, that we need to make sure those kidneys stay good? Think of the big C. What cancer medications? That's the big C, guys. Chemotherapy, right? All Are we awake? I mean, I came second. All right, so chemotherapy.
Their brains have been working.
Good. And I was like, well, y'all should know this part. Hopefully we went over that in the medications. Okay. But chemotherapy, right? So chemotherapy is super toxic. Not only does it kill abnormal cancerous cells, right? It kills normal cells. So typically you can put it in the same thing as hydrogen peroxide, right? I always tell them, don't use hydrogen peroxide to clean a wound. Let someone do that, and it's only so many times. Because what happens when hydrogen peroxide hits a normal cell that's not infected? It kills it too. It destroys it, right? So we should not be using hydrogen peroxide to always do the wounds. So chemotherapy is similar, right? So whenever we have a patient that goes on chemotherapy, we can guarantee they're going to lose kidney function, but we need to make sure that we monitor them closely so that they don't go into kidney failure. And then eventually we're going to need to go on dialysis. Okay. All right. Surgery. Why do you think surgery can also bring down your kidney function? What happens during surgery?
You get
Okay. Which is it's a medication. What else? But more specifically? No. What during surgery can cause kidney problems for your kidney function to decrease?
It sleep still.
No. Do I lose blood during surgery?
Yeah.
So do I lose fluids during surgery? Yeah. So fluid loss, right? So if I become a little dehydrated, my kidneys, again, remember, you're poking the bear, right? They're going to get upset and then be like, nope, I usually like my fluid, but now I'm losing it. And so then, of course, I'm going to start getting upset, right? My function's going to come down. All right. And then, of course, other treatments as well. So again, big thing here with your physical exam, right, is mostly urine. You're looking at the urine. You're looking at how much urine, what does the urine look like, edema, and of course, if they're having any types of pain. Now, if they're having CVA tenderness, right, what is that more indicative of, though? What diagnosis that has to do with the kidneys? How about a kidney infection, right? Pyelonephritis, okay? Or they have polycystic disease when it comes to their kidneys. They have lots of cysts in the kidneys. Then all of a sudden they have excruciating pain that puts them down to their knees, right? And then they have to go into the hospital because they have fever all of a sudden and they're urinating pus and blood, right? That's when one of those cysts ruptures, okay? So that is something that we always tell our patients, if you see that, you need to make sure you get to the hospital stat so we can give you IV antibiotics. Okay. All right. So diagnostics, some of the tests that we're going to look at, definitely your UA, right? And then of course, if it reflexes to a urine culture, that just tells us what organism is growing if their patient has bacteria in the urine. Okay. Then of course, specific gravity as well. How long do we have before a urine sample is no good after we collect it? Not 10, 30 minutes, 30 minutes. The moment that it reaches past 30 minutes and that urine culture or that urine sample is not refrigerated, it starts growing bacteria and urinalysis is thrown off. Okay, so the golden number is 30 minutes and that's as long as you have. So if you take a urine, and of course we don't put it in the tube system, right? Because then again, you're gonna have a really ugly mess, a smelly mess if that thing comes open for any such reason or if it gets lodged. So you need to hurry up and walk it or send someone to the lab with the urine sample or put it in a bag of ice and then walk it over there, okay? So that way it doesn't lose its integrity. All right, so what are we gonna do when we collect the urine sample? So I got it from my source. I had someone pee in the cup.
What time you got it, what day?
Very good. Okay. Make sure you do that because if not, I'll be like, what is this? And if it looks like apple juice or anything else, I'm like, what is this? Right? Exactly. Exactly. I mean, if it looks like pus, can you imagine where did this come from? Right? What part of the body? So we need to make sure we label it correctly. Okay. So the most common organisms in a urine sample, if they're growing bacteria, E. coli. Why do you think that is? Why E. coli? Why is that number one? because it has poop, because that hole is closer to the other hole, right? Okay. And then of course, so what are we going to teach our patients about? Maybe, or even our female patients, to wipe front to back, right? We want to wipe front to back. You would not be, I mean, you'd be surprised how many people don't know how to do that or don't know that that's what they were supposed to be doing, especially our older people, okay? Wipe front to back. Is it very common for a male to get a UTI? No, not at all. It's not common at all, right? Why? Their anatomy, their structure, right? It is so much harder for males to get a UTI because of their structure, right? Whereas females, we have several in one spot that can get contaminated into the urethra. Whereas in males, they don't have that, right? So if in a male, if you even see a tinge of blood and a few things of bacteria, we treat it automatically. We don't even wait, we don't ask, because normally we don't usually have symptoms like females have either, but we just treat them with antibiotics because it's very uncommon that they would have an infection in their urethra, okay? All right, very good. Okay, so other studies, like I said, BUN. If our BUN is elevated, what does that mean? What does the BUN tell us? It's more of a hydration number, right? Do you drink water? Okay. So like I have patients that come in, their creatinine's pretty good, their eGFR, I see lots of chronic kidney patients, but their GFR could be like 70, 60, which is still technically normal. But I'm like, but you were in the 80s before. And your BUN is high. I'm going to ask them, how much water are you drinking? Right? It would be high if it was not good hydration. It would be normal or low if they're drinking plenty of water, okay? How much is the amount of water that we want someone that has no problems like CHF or anything like that? How much water is good on a regular basis for you and me? 8 to 10 glasses a day, that's it? But what's a glass though to you? 2 liters, right? 2 liters, 60 ounces pretty much a day, okay? 60 ounces a day. So interpret that, because if I tell a patient, hold on real quick. If I tell a patient, you need to drink 60 ounces a day. Okay, well, is that 6 glasses a day? Like what's, okay, you guys can afford Stanleys, but patients on Medicare, can they afford Stanleys? So interpret that. What is 60 ounces a day? How many bottles of water? Just regular bottles.
60 ounces?
About 3 to 4, right? Because it's 16 ounce, close to 17 ounces per bottle. It's about 3 to 4 bottles of water. Yeah. So interpret it when you guys are doing patient education. Make sure you're interpreting it to where the patients can understand, right? When they say, oh, I drink a cup of coffee every day. Okay, but what's a cup of coffee, right? Or if they say, oh, I drink a beer a day. That's all I drink a day. Yeah, but are you drinking the tall boys or are you drinking the slims? Like, what are you drinking, right? So you have to really be accurate when you're asking these questions, okay? We don't normally do 24-hour urines very often anymore, okay, because we have some fancy exams now, but you might see that. When you're doing a 24-hour urine, we're checking for all kinds of specificities to the urine. Just make sure that this sample is one, because it might be on NCLEX, that you throw away the first sample, the first void. So the patient pees, you throw that one away, the collection starts on the next pee, okay? And then you keep this on ice. So you and your CNA have to make sure that you're making, that it has plenty of ice in the bucket, and you keep it at the patient's side, or if like they have a Foley, or you put it in the bathroom on ice and just constantly be checking it, okay? Because if not, like I said, 30 minutes off ice, we're gonna start messing with our results, okay? What was your question? I'm sorry.
What's the UTI treat? If men don't commonly get UTIs, then why do we treat for UTIs immediately then?
For the males, because of the fact that since it's not a normal thing for them, it can get, imagine sepsis, urosepsis, right? So if we see that they have bacteria, we're not going to waste time in the male, because again, how how far has the bacteria actually traveled in a male in order for us to get it from their urine, from their bladder? A long way, a long way. In comparison to a female that might be just less than 6, right? So in other words, they've had that bacteria in their system a lot longer than a female would have because it traveled a longer way. Okay, does that make sense? All right, okay. Good question though. Okay, so another thing that we look at specifically in the hospital is certain medications and certain procedures that we would put the patient through that might cause kidney problems, right? Kidney injuries. So the big one here is definitely the contrast in your CT scans, all right? Or if the patient goes for any type of interventional radiology procedure, or maybe cath lab for a heart cath, we use contrast in those types of procedures and tests in order to give us better pictures, right? But it's toxic to the kidneys. So we need to make sure that the patient stays hydrated after they drink water, or we give them IV fluids in order for them to flush that contrast out and make sure that we can excrete it through the kidneys. Another one is metformin, right? So metformin is the famous first-line treatment for diabetes, but long-term use of that medication definitely can cause kidney issues. It can cause chronic kidney disease. So when we're in the hospital, and this is something that you guys might, or if you haven't seen it in SIM already, but do we give metformin in the hospital?
Yeah.
No. We don't, because of the fact that it has to be held for 48 hours before we can use it for CT scans or any procedures. So it delays treatment. Okay. So that's why when your patient, and this is on NCLEX, when your patient goes into the hospital, they automatically convert to an insulin sliding scale. The question on NCLEX says, what do you tell your patient if the patient says, am I going home on insulin? Like, I've never been on insulin. I've only been on oral diabetic medication. No, this is the reason why we put you on insulin in the hospital. We take away all your orals, including metformin, because there are interactions to other procedural medications like contrast. And we want to make sure that we protect your kidneys. That is on NCLEX, so remember that, okay? All right. It is on there, I promise you. Okay, and then of course, like I said, making sure that we educate the patient. Mucomist is something that we give to reduce that contrast-induced nephropathy. So and that's also in, Mucomist is given either in pill form or in inhalation, okay? All right. Why do you think bowel prep is a consideration for causing a kidney injury? What does the bowel prep make you do? Pretty much. It like in and out, right? So it can dehydrate you. All right. You're drinking and drinking and drinking, but it's a laxative. So that's why they always say make sure that you're staying hydrated while also drinking the bowel prep. They put you on a clear liquid diet, right? So that way you don't get dehydrated during the bowel prep. Okay. Some of the procedures that we have in order to check the kidney, we do a bladder scan, right? That's pretty much you guys doing the bladder scan. What am I checking for with the bladder scan? What's it for? How much urine is in the bladder, whether after I voided, right? Just checking a post-void residual, how much urine is still staying in the bladder after I peed, right? Or if I haven't urinated and I'm like, it's getting kind of boggy in there, it's getting a little distended in the abdomen, then normally we will order for a bladder scan to see how much you're retaining, okay? If you can't pee, what are we going to order in order to get that urine out? A straight cath, right? We're going to do an in and out, and let's say, hey, let's get this out because they're not comfortable. If urine stays in one spot in the bladder for a long period of time, just like the same thing, if it's not cooled and chilled, it's going to grow bacteria. Now add food. Add diabetes, that's their food source. Sugar, right? Bacteria love sugar. Then that's where most diabetics have chronic UTIs, right? Okay. All right. We can also do a cystoscopy or a cystogram. So pretty much it's just going into the bladder and checking it out. Usually urologists are the ones to do those, right? Urologists and nephrologists work together. Nephrologists are concentrating on the function of the kidney, whereas the urologist is more like our surgeon. We send them for all of our treatments, all of our procedures, okay? You have a renal arteriogram. Why do you think I need that? Blood feeds the kidneys, right? Yeah, so we want to make sure that the arteries in the kidneys are open, right? That they're open, there's no occlusions, because then if we don't get enough circulation, the kidney starts to die, okay? All right, KUB, what's a KUB? Mm-hmm. When do we order a KUB, other than when we're looking at the kidneys, though? NG tube, thank you. That's an NCLEX question. Okay, so we don't order chest x-rays for an NG tube placement confirmation. We order a KUB. Okay, all right. We do CT scans, we do IVPs, we do renal ultrasounds. Anytime your patient comes into the hospital and all of a sudden they're like, oh, consult nephrology. Oh, the patient is having, decreased urine, or their urine looks super dark, or they have a UTI. We're doing a renal ultrasound right away. We need to check the integrity and structure of the kidney to make sure that there's no cysts, no stones, no obstructions, right? And we look at also the size of the kidney. One kidney can always be smaller than the other, but one should not be the size of a prune and the other one the size of my fist, okay? So that might be something that's congenital and the patients have no idea. When we have kidney transplants, how many kidneys do we have? Do we?
Excuse me?
Do they take out the bad one? After a renal transplant.
Oh. Well, I was like, oh, I think we got to.
After a transplant, it is more than likely that they do not take out the bad one. They keep the bad one in, they transplant the third one. So some patients have 3 kidneys. A nephrectomy is when they take out a diseased kidney. So know the difference. Transplant means I'm adding one, right? A functioning one. Doesn't mean I take one out, okay? If they take it out, it's because it's a diseased kidney, meaning that there's maybe cancer in it, okay? So there are some people that have 1 kidney. It was a trick question. Pay attention.
What's the reason of leaving the kidney there?
It causes more trauma because it might be still getting vascularity. It just doesn't work. So they leave it. There's more concerns actually taking it out. So you'll see patients with 3 kidneys, but only 2 of them are functioning. Okay. All right. So this you definitely need to know. It is on your exam. Okay. So pre-renal, there's 3 causes of acute renal failure. You have a pre-renal, which is pretty much that the kidneys aren't getting enough perfusion. Okay. So this happens during like sepsis or any type of hypovolemic shock. There's intrarenal, which means that the kidneys have been damaged because of medications, toxins, and then they also got reduced blood supply to the kidney. And then there's postrenal, and this is where your stones come in, or obstruction because of renal artery stenosis, okay? So just remember, postrenal is obstruction. Intrarenal, it happens inside the kidney and it's direct damage to the kidney because of toxins, medications and drugs. And then pre-renal is all about perfusion. So if they don't get enough circulation, you're going to get that type of acute renal failure, okay? So that's a good slide to know. Okay, so phases of the acute kidney injury. The initiating phase is pretty much when it first starts, okay? That's when the infection already hit the kidney, or there was damage because of a medication, okay? So you're going to start seeing that this patient their urine output is not as good as it was. It's slowing down, okay? So if it's slowing down, it's getting more concentrated, it's darker, it's more sedimenty, and it smells, right? It smells very, very strong and acidic. You're looking for, because it's getting concentrated, you might have higher potassium levels in the patient, right? So just think of dehydration. If I take out the water, then everything else is left there very concentrated, okay? And we're going to look at the creatinine. Remember, if we're holding on to too much creatinine, it means that we're not excreting the bad stuff out. We're holding on to waste. All right. So you have the diuretic phase where, again, this is after treatment. We want to make sure we gradually increase that urine output. This is where you're starting to see that your creatinine is starting to clear from the system. Okay. And then of course, you have your recovery phase. Excuse me. This can take up to about a year. So every time that a patient comes into the clinic for follow-up, we always tell them, okay, it depends on how well you can bounce back. The younger you are and the less comorbidities, well, guess what? Your kidney function might recover within 3 months. But the older you are, the more comorbidities you have. It could be from a year to even longer than that, or it may not recover to like 100% again. Okay. We had a 24-year-old that came in. This is why I'm not necessarily a supporter of any type of supplement when you guys work out, especially creatine. Okay. So 24-year-old, and he was a personal trainer. He drank nothing but creatine, no water for days. And so he ended up with a acute tubular necrosis, meaning that he gave himself permanent kidney damage at 24 years old, where he was once at 123% or 120% function. His baseline is 60%, and he's 24 years old. So, and it's not just one kidney that was compromised, it was both. So again, and that was just because of all the stuff that he was putting in his body. Let me see. And then of course the outcome of the AKI, case in point with that one patient. But other than that, I have other patients that come in, they have a real bad AKI after a UTI, and they go from, needing dialysis for a couple of days to completely recovering and back into the 90s. Okay. So again, I put these slides so that way you guys can use them as study tools, and you would just have to print them out. Okay. But again, for pre-renal, you're looking at hypovolemia, right? That can cause hypoperfusion. Heart failure, why do you think heart failure might be a pre-renal issue? Because aren't heart failure patients full of fluid? Correct, but why do you think though? Because we said that maybe dehydration can cause, that hypoperfusion can cause the kidney injury, but heart failure patients usually have too much fluid. So why do you think that is? Because where is the fluid in a heart failure patient? Think of their symptomology. It's in their lungs, right? If they have left-sided heart failure, it's in their legs. If they have right-sided heart failure, it's not in the vascular system. It's outside the vascular system. So they have fluid, but they're not using it correctly, right? Okay. So remember, you have to kind of picture these patients. Renal artery stenosis, meaning we're not getting enough supply because of stricture. And then of course, certain medications. So ACE inhibitors, ARBs, NSAIDs, what are some examples of those? What's an example of an ACE inhibitor? Lisinopril, so your prils, okay? What about your ARBs? The Artans, right? Losartan, right? Those are the Artans, okay? And then your NSAIDs? Ibuprofen.
I think that's
Aspirin. Yep, it's an anti-inflammatory. Meloxicam. Diclofenac. Yep, exactly. So those are not your kidney's friends. We don't like those. The moment that your kidneys are injured, we say, stop all of that. Tylenol is your friend. Now, if your patient has liver disease at the same time, they're SOL. They can't take it both. Okay. All right. ACE inhibitors and ARBs, what lab do we have to make sure that we monitor, especially in a kidney patient that these meds can cause? What lab? What can it produce more of if I'm on an ACE or an ARB? Potassium, right? So as soon as you see a chronic kidney patient and then they're on ACEs and ARBs, because those actually do help some of them, but we need to monitor their potassium level. Because if it starts to creep up, either I'm taking off that medication or I'm giving them something to decrease their potassium levels, like Lokelma, okay? All right, very good. This is just for your studying purposes. I'm a picture person. I'm a very visual and hands-on person. If I read, I can read out loud and I still don't know what I'm reading to you. Okay, so that's just me. But I like pictures, so I included this and how it helps manipulate your blood pressure. Okay, so just remember that your kidneys are also responsible for your blood pressure management. Okay, any concerns or questions about the pre-renal AKI? So we know it's hypoperfusion, right? Not enough circulation. Okay, good. All right, intrarenal. These are the causes that are made that are these are caused by medications, infections like your kidney infection, certain systemic diseases like lupus, right? The autoimmune disorders where the body attacks itself. First organ it's going to go after are the two small little kidneys. Okay. All right. And then, of course, different toxins that we're not able to get out of our system, kind of like contrast. Okay. All right. So big thing here is early detection. You want to make sure that you're looking at these risk factors. And then as soon as you see, oh, I have a patient that just had a heart cath, let me check their kidney function. Oh, I have a patient that's taking metformin and they've been on metformin since they were 20 and now they're 70, right? I need to look at their kidney function. Make sense? Or I have a patient that was just diagnosed with lupus. Normally that is your patient that is the female, most common, right after they had a baby. They start getting diagnosed with lupus, okay? Lupus usually presents itself. Again, it's a genetic disorder, but it wakes up the bear after a major stress, physiological stress. Well, for us females, it's childbirth, okay? So that's a physiological stress, and that's usually when we start seeing those females get diagnosed with lupus. And then the first organ, like I said, it attacks is the kidneys. So they get lupus nephritis. All right. So again, we're looking at the underlying cause of those issues. So that way, like if you're a lupus patient, they're seeing rheumatology for treatment. You good?
We can take a quick break.
Let me put-
Okay, that's okay.
Let's see.